Welcome to Vision 2020 USA's Spotlight Series. Today's topic is Access to Eye Care, featuring Dr. Susan Primo, the Director of Optometry and Vision Rehab Services and Professor of Ophthalmology at the Emory Eye Center, Dr. Angel Scansera, an Assistant Professor of Ophthalmology at the Illinois Eye and Ear Infirmary at the University of Illinois Chicago, Luke Ertl, the Program Director for the Association of Clinicians for the Underserved, Dr. Amy Moy, the Senior Director of Community Health Initiatives and an Associate Professor of Clinical Optometry at the New England College of Optometry, and Dr. Diane Russo, an Associate Professor of Optometry at the New England College of Optometry. The Spotlight Series is hosted by Dr. Rajiv Ramchandran, an Associate Professor at the Flom Eye Institute at the University of Rochester, and Dr. Dean Van Asdale, an Associate Professor at the Ohio State University College of Optometry, leading members of the Vision 2020 USA Executive Committee.
All right, so while people join, welcome to Vision 2020 USA's Spotlights. Dean Van Asdale and I have been running these for the past year or so, and we are trying to highlight what folks in the United States are doing, especially regarding access to care and improve eye care specifically, and improving awareness of the need for eye care in our country. We've found a lot of great speakers and great projects throughout the United States, and we're learning from each other. And we record these because Dean is writing up basically all of these meetings, and we'll hope to eventually put it into some type of format or a white paper that we can get out there and just show everybody what's been going on in the United States. Because, Vision 2020 USA, or Vision 2020 in general, was an initiative started by the WHO and the International Agency for Prevention of Blindness in the 1990s to increase access to eye care. And the goal was to end avoidable blindness by year 2020. Well, we're past that, and we have a lot more work to do. And the United States, this group really formed later in around 2009, and some people on this call were among those who were there in the beginning, including Victoria. So it's great that we have all of you here, and the list keeps growing. Wow, this is probably our largest meeting, so this is wonderful. So and we hope to have in-person meeting at ARVO, the Association for Vision Research and Ophthalmology, which is happening in Denver in May of next year. So if you guys are going to come to ARVO, please do look out for an announcement of this meeting. There's also some discussion in doing something with the newly renamed group at ARVO, which was used to be the Clinical Epidemiological Group, which is now called the Clinical Data Science and Population Health Group. And that section of ARVO has a lot in common with what we're doing. A lot of us who present at ARVO often present in this section. So that's what's going on at Vision 2020 USA. We also have elections coming up for our executive committee, because it's been 2 years since we had our last election. It's a 2-year cycle. So Dean as vice chair and I as chair have been doing this for a couple years, but there are elections coming up. So if you guys are interested in being part of the executive group, who kind of help lead the show and organize what we do, please do reach out to us. You can email Ann Wilcock, Wilcock at preventblindness.org, or you can go to our website, vision2020usa.org, and let us know. Dr. Mitch Brinks is the one leading that, as he is the board chair of Vision 2020, and they're basically working on that right now. So with that, Susan, you have a beautiful group here, and I'll let you chime in. The topic is increasing access to eye and vision care, and you're going to be reviewing kind of this area of the U.S. healthcare system. But you have a good group here, and I'll let you introduce everybody. So Dr. Susan Primo is an optometrist and faculty member at the Emory University Eye Institute, and we're very excited to have her and her team here to talk more about the importance of increasing access to eye care in the United States.
Good. Thank you. Luke, you want to go ahead and share the slides? Luke is going to be our slide keeper and our official timekeeper. So just give us a signal if we're going over our allotted time.
Sure.
Good. Next slide, please. Good. Next slide. All right. So well, one before that, sorry. So first of all, thank you, Rajiv and Dean, for inviting us and allowing us to present what we hope to be offer a good conversation and share our knowledge with you. You can see the presenters there and you already have the information ahead of time. I'm going to stick to my notes so we stay on time here because we've got a lot of stuff to present, but thank you again. We've got, again, a team of passionate folks about the model of care that we're going to present, and hopefully, again, we can share our knowledge. Next slide. So today's objectives are we're going to talk specifically about community health centers as a delivery model for improved access to comprehensive eye and vision care. And so we acknowledge that there are other models of care out there, certainly from telehealth to mobile units to other types of delivery care, but we're going to specifically talk about community health centers as a delivery model. When we think about this, we think about the hub and spoke model for on-site care. So again, at the spokes, whether it's rural or urban, there can be health centers that certainly don't have on-site care, and we are realistic to know that every health center cannot have on-site vision and eye care. However, we believe that there should be a hub, or at least a place where people, if they fail the screenings or fail whatever model of care they're utilizing, that they can have a place to go to get that on-site care, because we all know that follow-up certainly is a challenge. We're going to highlight some collaborations and research efforts, and then we're going to give you a successful case example from Boston. Next slide, please. So just in sort of dialing or stepping back just a little bit to talk a little bit about more about community health centers and sort of their federal overarching who designs them and who oversees them. Basically in the United States, that there is the Department of Health and Human Services, HHS, and there's several agencies and programs that fall under that, including the CDC, NIH, the Indian Health Service, and also HRSA, otherwise known as the Health Resources Service Administration. So you'll kind of hear HRSA thrown out in this talk a lot. Under HRSA, or within HRSA, I should say, the Bureau of Primary Health Care, BPHC, so another abbreviation, is the one through which the community health centers are funded by. The Section 330 of the Public Health Service Act is a direct federal legislation that, again, is the overarching industry or agency, if you will, that oversees funding for community health centers. It is to the tune of about $250 million currently. That obviously may change, hopefully not, but that is there. You know that it primarily serves an underserved population. We'll talk a bit more about the specifics there. One of the key features of community health centers, we believe, is that it provides comprehensive care, predominantly primary care services, but that does include dental, behavioral health, and some other issues, as well as other sort of, again, translating services, all of that. But we really believe it is a perfect model, and it serves as a medical home. It includes an interprofessional and multidisciplinary sort of team-based care. And so patients have access to all sorts of things. As I mentioned, not just the primary care services, but access to social work, patient navigators, caseworkers, and enabling services. Certainly patients that visit these health centers qualify for enhanced reimbursement, or I should say the health centers qualify for enhanced reimbursement from Medicare and Medicaid. It's called a wraparound payment. You may have heard of this. And so it basically has to do with programs or hospitals or centers that see high acuity patients and that are eligible for these basically enhanced reimbursement fees. One of the key features, and you see I have it bolded there, is that health centers offer a sliding fee scale. So essentially no one is turned away. And so they make it work for whatever the situation may be with an individual patient. There's an ongoing quality assurance program. And one of the interesting things about community health centers, which you probably won't be surprised at, is that they are community health centers located within a community. And so the governing board is more than 50%, 51% at least, consumer board. And this becomes important because now you've got a health center or a medical care system that is driven predominantly by the community and what's needed in that particular community and the consumer board. Next slide. So just to give you some background stats here, again, and some of the risk factors, 1 in 3 living in poverty, 1 in 4 racial and ethnic minorities, and you can sort of see the rest of that. And the key feature here is that these very same people that you see that community health centers serve are medically vulnerable to particular medical problems, including diabetes, high blood pressure, and so forth, but also are particularly vulnerable to vision and eye care problems and at risk for vision impairment. So this is essentially the population that is at high risk and those that we want to serve. Next slide. A little bit more about demographics there. Again, you can see the breakdown there of the sort of the racial demographics there. And again, as I mentioned a little bit earlier, is that different populations of the United States, different ethnic populations are at higher risk for eye disease and visual impairment. This research has been done. I think everybody on this call is familiar with it, including research recently on sort of African Americans and the burden of undetected eye disease to Latinos and Hispanics, which tend to have a higher rate of diabetic retinopathy. But we want to focus certainly more on more than diabetic retinopathy. There are other diseases as well. Also, people are at risk of the social determinants of health. Again, I don't need to tell this group about this call. And there's research, including from Angel Scanzera, about sort of transportation in particular. So we know that this diverse patient population is going to be at higher risk for eye and vision health problems. Next slide. A little bit more just about the people with complex needs. We know that veterans, even though there is a VA system, that veterans, they're still frequent community health centers for the most part because they are in the community where they live usually, and they have service-related injuries and illnesses, accidents, exposure to chemicals, et cetera. School-based health centers also frequently serve a higher percentage of sort of Black and Hispanic populations. And then agricultural workers face risks related to vision UV exposure and other things. And so again, this population is at high risk and certainly deserves to have equal care. Next slide. So health centers rely, as you know, on federal and state funds. And this is from 2023 stats. And so, half of the patients are certainly on Medicaid. And so if you add that up, it's really 70% are either on some sort of, 78% on some sort of public funding. And so again, we know with what's happening with in the legislature now, and that this particular funding source is, I won't say under attack, but I'll be a little soft in that, but it is at risk for being decreased. And so health centers heavily rely on this funding. And so you can imagine that it will cause a very, very difficult problem if that funding stream is no longer there. Next slide. And sort of lastly, again, we sort of compiled this group of slides, not so much to spend some time talking about this because we could talk about it for hours, honestly, but to really just to show that the patients that frequent health centers typically have lifestyle risk factors as well as some of the other risk factors that I mentioned. And so you can see tobacco use against food insecurity. And so again, from a research standpoint, these provide important points for patients who frequent community health centers and why we are advocating that community health centers become an access point as much as possible, given the constraints of federal funding and all of that, but become an access point for eye and vision care on site. Good, next slide, thanks. I think it's you, Luke. Yeah.
All right. And as we said earlier, my name is Luke Gordon. I'm the program director with the Association of Clinicians for the Underserved. On screen here, you'll see this is a little bit of an older map from 2021, but it gives you an idea of the distribution of health centers across the U.S. So each blue dot represents one health center organization, and there are over 1,500 organizations, and they provide care at over 15,000 service sites across the country in all states and territories. And again, this is a little bit older map, but it gives you an idea of the percentage of health centers that provide vision services by state. So in 2019, 26% of health centers provided vision services to their patients. It increased to about 32% in 2021, but now, or at least as of 2024, it's back down to about 26% of health centers providing vision services. So a requirement of all health centers is that they have to provide an annual report to HRSA on their workforce, their financials, patient demographics, visits, and more. This slide provides details on the workforce, clinic visits, and provider types at health centers. So over here on the left side, you'll see the vision services full-time equivalents or FTEs. We have 508 optometrists, 45 ophthalmologists, and then 849 other vision care personnel. So that's anybody from opticians, techs, front desk staff, managers. The UDS lumps them all together. Then on the right side here, you can see vision services visits. So a little over 1 million or 93% of visits were done by optometrists in 2024, or excuse me, 2023. And then 86,000 by ophthalmologists, or about 7%. But despite this importance of vision care, as I said earlier, only 26% of health centers nationwide offer vision services through an optometrist or an ophthalmologist, and that only comes out to about 3% of patients, or a little under the 3% of patients accessing these services each year. So if we want to look at the unmet need here, as of 2023, HRSA's recommended benchmark is 36% of health center patients getting access to vision services. But as I said a minute ago, it's a little bit less than 3%, which comes out to about 10.7 million patients who do not have access to vision services at health centers. And if we looked at a ratio of 1 to 10,000, or one provider to 10,000 patients, that would be a little over 1,000 eye care providers that would need to be hired to address all that need. So some of the barriers here for health centers starting up vision services. First of all, the high startup costs. So health centers operate on razor thin margins. So that high startup cost of the equipment, space, and recruitment of a provider create all those things create barriers to opening eye clinics. Furthermore, eye care is excluded from the definition of preventive and primary care under Section 330 of the Public Health Services Act, which is the primary form of funding, federal funding for health centers. That means that the governing board and management must find a funding mechanism to support the establishment of an on-site eye clinic. And with eye care designated as a non-mandated specialty service, community health centers have to rely on alternative funding methods like federal funding, federal expansion grants, excuse me, state or local funding, loans, bonds, private fundraising, so on and so forth. A lot of health centers also experience workforce challenges. So the National Health Service Corps, which is really a key tool for health centers and other safety net organizations, or health safety net healthcare organizations, to provide or to recruit providers. Eye care providers are excluded from the NHSC. Optometrists were included back at the beginning, but then were removed in the early 2000s and have not been, reintroduced since then. We're also hearing anecdotally that a lot of health centers in rural areas are having a difficult time recruiting providers. They're purchasing the equipment and then maybe waiting a year or more to hire somebody to find a candidate. As Susan mentioned a little bit earlier, there's about 11% of health center patients on Medicare and 50% on Medicaid. And this creates, or there are some barriers for getting access to vision services through these two payment methods. So traditional Medicare does not cover eyeglasses or contact lenses. And then for Medicaid, vision care is an essential benefit. So the amount of coverage and how often patients can get get glasses, get exams, things like that, it varies from state to state, creating barriers for those patients. Lastly, there's a lack of national and state level support. So health centers have a big network, support network with national training and technical assistance partners, or NTAPs, at the national level, and then also at the state and regional level with primary care associations and health center controlled networks. So the NTAPs are funded by HRSA to provide training and technical assistance that's free for health centers, and they cover a lot of different topics, from recruitment and retention of the workforce to oral health services to working with ag workers. migrant populations, lots of different topics and areas, but nothing's dedicated to supporting vision services. And then primary care associations do a lot of the same sort of work with, training technical assistance. They also do policy and advocacy work at the state level, but there's no funding directly to support vision services at that level. And then lastly, health center controlled networks are either state or regional collections of health centers or groupings of health centers that they it's an organization that supports data and analytics, QI, billing, reimbursement, all those sorts of things. But there's not really much in the way of support on that end, or no federal funding to be able to help support them when all these organizations that I just listed provide or get federal funding to support that, support their work. So jumping into a little bit of what's been going on at the national level to help support health centers, my organization, the Association of Clinicians for the Underserved, we received a grant from the Centene Foundation to provide small startup grants to health centers. So it was between $5,000 and $25,000 to start up vision services, and we provided them to 29 health centers. And as a requirement for that grant, they had to provide data on how many visits they had in that first year. How many patients were seen, and as you can see on the screen, how many we had over 25,000 comprehensive eye exams, over 12,000 pairs of glasses distributed. Other things we provided through this grant is training technical assistance through our Vision Services Committee, which is a volunteer group of mainly optometrists as well as health center leaders and administrators from around the country. And we also established a community on Facebook for peer learning, peer support, networking, those sorts of things. And then lastly, developed a number of educational opportunities and resources. You can find out more on our website. And also did some of this work in partnership with other organizations that Susan's going to jump into here now. Susan?
You're muted.
My laptop is acting up on me. Sorry about that. Well, one of the things that we realized is that, collaboration is key. I think we all realize that. And so back in 2022, 2023, sort of really brought in my friends from Prevent Blindness who are on this call today. So kudos to Jeff and Kira and Julie and Donna for making this happen. But we realized that more of a transdisciplinary approach was needed to really, sort of move the needle, if you will. And so we partnered with NAC, National Association of Community Health Centers, and as well as ACU that was already mentioned. And so we did this really, and we still have this really innovative sort of webinar series called Eyes on Access that has reached thousands of community health center staff and stakeholders. And one of the things that's beautiful about the webinars is that, of course, they can be found on the website of NAC and they can be played over and over again. And so you can see that we've done a variety of ones from just intro talks about, how we can incorporate ourselves on site, to billing questions, to financial questions, a whole gamut. And then in 2023-24, the same team of people, along with the School-Based Health Center Alliance, sort of did more on the children's front, and again, reaching thousands of health center staff and stakeholders. And so, the most recent endeavor is with the fact sheet. This is predominantly, I believe, between NAC and Prevent Blindness, really working on this nice one-pager, I believe it is, maybe it's a page and a half fact sheet. And so all this to say is that we realize that these national partnerships are important. The national partnerships are critical, and we are always finding innovative ways to continue them. Go ahead, Luke.
All right, so that's me. So our next portion here is just to be giving sort of a very brief overview of what's been published in the literature, probably over the past 20 years or so. And so you can see here just this sort of screen grab from PubMed. There's definitely an upward trend over the past 20 years of what's being published in this area. And you can see the keywords that were pulled from PubMed. Next slide. So the next two slides really are just screen grabs of some of the titles of the articles that are being published in this area. Next slide. Again, we're not going to cover these specific articles in depth. This is just to give you an overview, to show you that this is part of that upward trend. Next slide, please. So back in the earlier 2000s, the American Optometric Association did have a community health center committee. And around 2008, 2009, they published at least 4 papers, and that we have 2 highlighted here. And then again, on the next slide, we have the titles of the other 2 papers. So there has been some activity in this area previously. There was maybe a little bit of a lull. If you can go to the next slide, now we're starting to see some more of a resurgence of interest in this area. So there is definitely history, previous work that's been done. Some of the individuals that have done that work are on this call. So certainly there's a lot of passion for this area and health centers. And most recently, the American Academy of Ophthalmology formed a task force on ophthalmology and community health centers. So December of 2022, that was formed. The goal is listed there. If you can go to the next slide, we have the members listed. So of course, this is an American Academy of Ophthalmology task force. So of course, ophthalmology is represented, but I am going to point out that optometry is also represented there. So myself and Dr. Scanzera are members of that task force. Both optometry and ophthalmology
Somebody needs my phone.
are collaborating as part of this task force. Next slide, please.
Like it's a glitch with the like it's freezing.
So there are 2 papers so far that have already been published as part of the work from this task force. So this is the first paper that came out, and this was cross-sectional. It used data from the Uniform Data System, UDS, and the American Community Survey, ACS, 2017 and 2021. And if you can go to the next slide, again, we're fast and furious right here. So we're just going to highlight some of the higher level key results from each of these papers, just in the interest of time. And what they found, that there was vision care offered in 2017 at about 28.5% of FQHCs, and then 32% in 2021. But only about 2.6% of FQHC patients were receiving eye care in 2021. I believe that increased to 2.9% in 2023. One of the main findings from this paper, though, was a bit of a paradox, because they did find that while vision services were more likely to be offered, because they were comparing health centers that offered vision services versus those that didn't, vision services were more likely to be offered in urban FQHCs and neighborhoods with a higher percentage of Hispanic and Latino residents, those that had Medicaid coverage, and households that did not have cars. Those certain patients, and they identified those that were Hispanic, Latino, those that were insured by Medicaid, and those that were lower income, were not actually accessing the vision care services within those health centers when the vision care services were available. So that was one of the main findings, but somewhat paradoxical, that came out of that paper. Next slide, please. The second paper that came out of the task force was a systematic review. So it's the title there. And if you go to the next slide, just so that we can highlight some of the findings there. So they did highlight, it was sort of twofold, looking at on-site services, vision services that were provided, and also telehealth services. So on one hand, the on-site services, they did find that there was patient interest in accessing those services, but there were sort of 2 levels of barriers to accessing those services: patient level and system level. So with the patients, they found that there were challenges with cost, insurance, transportation, as Dr. Primo had mentioned earlier, and health literacy. And then on the system level, they found that the health centers themselves were having difficulty finding clinicians. to actually work on site at the health centers, that there were inadequate reimbursement rates, and then just competing priorities within the health centers themselves. And Dr. Primo touched on some of that earlier as well. And then when it comes to telehealth, just in general, they found that it expanded access, particularly in rural areas, improved outcomes, and could be cost effective, but that implementing the telehealth had its challenges as well, that there were poor image quality. They found that there was long wait times when they were trying to refer patients for in-person care after the telehealth screening, and that there was somewhat of a burden being placed on medical assistants who were performing the fundus photography. Next slide, please. Another paper that didn't directly come out of the task force, but again is a publication that was recent and is in this topical area, just focused specifically on Florida. And so they were trying to get a sense of what was, how commonly vision care services were being provided in the FQHCs just in the state of Florida. And if you go to the next slide, please, we'll just focus on the results. And mostly what they found, key results here, is that slightly less than 9%, so only 8.9% of the FQHCs in the state of Florida were offering eye care services, which is much lower than the national estimates, which are anywhere between 25 and 32%. So there is quite a large gap in vision care services being offered in the state of Florida and their FQHCs. So that was one of the more significant findings from this paper. And I believe if we go to the next slide, I will be handing it off to Dr. Scanzera.
Thank you. I feel like if anything, this is a repetition of we could do better for our patients when it comes to expanding access. So this was a viewpoint that was recently published, and just some highlights. It mentioned that 70% of children referred from FQHCs to eye specialists are not completing that visit. And their recommendation, this is Megan Collins, pediatric ophthalmologist, was to expand on-site screening and eye exams. And then a limitation, I think, that each study had was the UDS data is really limited. And so improving data collection could help us have better measures. I noticed Dr. Quadros mentioned in the questions, we can go over it later, but really what's the demand for referral to specialties? And I think before we even touch on that, there's a lot of limitations when it comes to referring outside of the health center. And so having that hub and spoke model is really key here. Next slide. And this next study, this is not FQHC related, but I think it's a really good point to bring up. This was done by our colleagues in Australia, and it looked to evaluate a collaborative care model between a university-based optometry clinic and a public hospital ophthalmology department. The ophthalmology department was really getting overrun by referrals, and what they ended up doing was created this model where final year optometry students under supervision followed these clinical protocols and were able to see some of these patients, and it ended up decreasing the amount of patients needing to be seen by ophthalmology. So about 18% of patients were appropriately escalated to ophthalmology care. Next slide. My point here is really that collaborative care between ophthalmology and optometry is really safe, effective, and scalable. And I think it's something that when we think about federally qualified health centers and improving access, is if we work together, we could do so much more for our patients. Next slide. So going on, we've talked about the AOA, we've talked about the Academy of Ophthalmology. In March of 2024, Diane and I started the American Academy of Optometry Community Health Center SIG. It's kind of a continuation. In this case, I think there was a lot of interest in networking and collaboration. And so our main goal was to offer a channel for collaboration and networking. Our first business meeting was really just we found our people session, it felt like. We also want to offer potential opportunities for research and advocacy. And so we do have a research subcommittee with this group, and then to offer an avenue for hosting employment events, creating partnerships with organizations, promoting health equity, and increasing providers within the health center network. Go on to the next one. And so far there's been one paper, this was just started last year by Dean and Susan, who were on the call. And this was to highlight the NASM report and really advocate for policy changes and resource allocation in community health centers. And There is one more, you can go ahead to the next slide. There's one more that's been submitted. And I think the more that we continue to put this into the literature, we really can start building a case for improving access and policy changes. And then I just want to highlight some upcoming events at our academy. So the big one is our joint symposium between the Community Health Center Special Interest Group and the American Academy of Optometry's DEIB committee. And this is Vision for All, promoting health and collaboration in community health centers. The keynote is Michael Curry, who is the president and CEO of the Mass League of Community Health Centers. It's also including Dr. Essence Johnson from Black Eye Care Perspective to talk about the importance of diversity in these settings as well. And then some other, we have the vision and collaboration driving positive health outcomes in community care. We have our business meeting on Thursday, October 9th. And there's also a networking event later that evening that we can, if you're on the communities, the Academy communities, that's posted on there as well. Next up, we'll go right into Amy.
Thank you, Angel and Diane. I wanted to mention that the symposium that Dr. Scanzero was talking about, we not only have those speakers that she mentioned, but we've invited CEOs and CMOs from our community health center partners in Boston, as well as someone from the National Association of Community Health Centers. So we're super excited to have such a great audience and to make it interprofessional even in the audience so that they can hear this great message. So I want to continue on our discussion and go to a crucial aspect of sustainable eye care access, which is educating the next generation of community health center optometrists. The foundation for this was laid back in 1969 with the first partnership between a community health center in Dorchester, Massachusetts, and the New England College of Optometry, or NECO. In 1972, that community health center became an official community health center, as the federal classification of FQHCs was started. This pioneering model has had a remarkable impact. Since its inception, NECO students have provided care to over 1 million patients in community health centers. Next slide. Today, the NECO Health Center network is extensive with 15 health centers with whom we are affiliated. There are 9 contracted health centers where both faculty and students are present, and 6 affiliated centers for student rotations. This demonstrates a long-standing and successful model for integrating optometric education into community health settings. We have 30 NECO faculty assigned to health centers for their clinical role. Some are full-time and some are part-time, for a total of 16 FTE. Every final year student at NECO is required to rotate through a community health center and likely rotated through a health center in their second and third year as well. In fact, a third of all second and third year placements at NECO are in our health center network. Next slide. So this map of Massachusetts provides a visual representation of community health centers in Mass with eye care services. Those blue circles mark where there is a health center with an eye clinic. And as you can see, there's a significant presence of eye care services within Boston, but also spread out and scattered across the state. And 31 out of 50 health center sites having eye care, out of those, almost half of those are affiliated with NECO. The concentration of it, though, you can see is particularly dense in Boston, which highlights the success of the integrated model and the importance of collaboration between NECO and the Primary Care Association, which I'll talk about in a second. There's still work to be done. As you can see, there's large areas of land without eye care services in health centers. And while there may be other eye care services in those areas, many do not take Medicaid, and this causes an eye care desert for those who have barriers to health care in relation to healthcare coverage, insurance coverage. Next slide. I would be remiss if I didn't mention the importance of NECO's strong relationship with the Mass League of Community Health Centers. The Mass League enthusiastically supports the importance of eye care in the FQHCs and even has an eye care forum for all eye care directors in the Commonwealth. Partnerships between the PCAs and optometry schools and other eye care associations are vital to the success of community eye care in terms of policy, reimbursement, interprofessional care, and inclusion in essential care services. So this was a study, a case study written up by NAC to put a spotlight on NECO's partnership with the Mass League of Community Health Centers in the hopes that it would help other states to form similar partnerships. Next slide. So now that I've set the stage, I want to go more into detail for you about the experience that NECO students have in their community health center placements. At NECO, there's a strong emphasis on preparing students for the realities of community-based care. The curriculum includes a focus on culturally inclusive care, which is essential for serving the diverse patient populations of health centers. They also learn about social determinants of health throughout their first and second year, and the students gain interprofessional experience by observing their preceptors as they work with other healthcare professionals during their rotations, whether that's with interpreters, social workers, pediatricians, nurses, or other vital departments. The geographic proximity of NECO to numerous health centers in the Boston area is a significant factor in facilitating these valuable student placements. So while we're often asked to send students out into Western Mass or Southern Mass, it's difficult to assign students who need to return the same day for classes. I've had several students tell me, though, that once they graduated, they realized how much NECO's program had prepared them to serve patients from all backgrounds. And that's the ultimate win. We are so proud of this. Next slide. Beyond the core curriculum, there are specialized residency programs designed to cultivate leaders in community health and ocular disease. NECO is affiliated with several such programs, like at the Dimmock Center, Lynn Community Health Center, Dot House, and Providence Health Center. These residencies are accredited by the Accreditation Council on Optometric Education, and they provide in-depth experience with residents rotating not just in their community health center, but also in nearby hospitals and specialties, including pediatric optometry, low vision rehab, and general ophthalmology. It's worth noting that some of these graduates of these programs have gone on to establish new eye clinics in FQHCs, demonstrating the direct impact of this advanced training. Next slide. So this leads us to the broader topic of workforce development. There is a clear pipeline to encourage careers in community health that starts with positive student experiences in community health centers, progresses to specialized residencies, and ultimately could lead to faculty positions or clinical roles in the community health setting. Student-led initiatives like the Community Health Club further fosters this interest. While the Community Health Club at NECO is the first of its kind, we're hoping to have the club propagate at other optometry schools and to have more of a movement so that students understand that community health optometry is a career path. Additionally, as Luke mentioned, optometry is not included in the National Health Service Corps, and it is involved. It does include optometry in the Public Service Loan Forgiveness Program, but the NHSC allows for shorter commitment and faster loan payoff, while the PSLP is a more long-term commitment and offers income-based payments. So having eye care included back into the NHSC would support the high demand for more eye care providers, especially as the starting salaries for new graduates continues to increase in many sectors. Next slide. The landscape of healthcare policy and administration has a profound impact, as we know, on the availability of eye care in health centers. One major challenge is how optometrists are classified by insurance companies and by accountable care organizations. They can be categorized as either medical providers or allied health providers. This distinction can create significant barriers to care. For example, in an ACO structure that classifies optometrists as allied health providers, medical eye issues may need to be referred out, creating delays and potential gaps in care. This, coupled with low reimbursement rates, can make it financially challenging for FQHCs to open or expand eye care services, ultimately limiting access for patients. The most successful models are those that fully integrate eye care into the primary care framework, which has been shown to produce extensive health benefits and reduces the financial burden on the state. Next slide. So we have some opportunities after you've seen all of us speak. Despite these challenges, there are numerous opportunities for progress. Collaboration between eye care professionals is absolutely essential to address the social barriers that impact visual health and to conduct the research needed to document eye care needs and develop structural solutions. We must also focus on building the workforce for the growing population that needs eye care and advocating for policy changes that prioritize visual health as an essential service. By including eye care in the integrative care model, we can make significant strides in improving health outcomes for all. Next slide. So that concludes the formal part of our presentation, and we welcome any questions that you may have.
That was wonderful, Susan, Diane, Luke, and Amy. This is a great summary of where we are in terms of healthcare in the public sector here in the United States. And it shows that it is needed a collaboration between all eye care providers and those champions of eye care. Um, Dr. Carter has had a question on a referral. So now you brought it up that it was challenging, we can do a general eye exam and give some medical care, but what if they need subspecialty care, ophthalmology care, and surgical care? What is the next step in a lot of the cases? Like what happens in Massachusetts with that example?
I could speak for the Boston area health centers. We have very strong relationships with the neighboring ophthalmologists who are in hospitals nearby. And so we even had a special a process to get our community health patients in sooner because sometimes the wait was 4 or 5 months. And so they were able to expedite their appointments and get them in, assign interpreters, and create that feedback loop for us. So I think we have pretty good processes in place, but it takes time to foster those relationships. But it's very clear that the wait for ophthalmology is long and we can help.
Yeah, I can add on that in Chicago. Miles Square Health Center is a part of the University of Illinois. And having spent a few years there, our optometrists that are at the health centers are part of the faculty in the Department of Ophthalmology, which does help foster the relationship. I think it's really simple when it comes to patients with Medicaid because we can refer them, get them in timely care. But when it becomes more challenging is when these patients are uninsured because while we do take charity care, it's usually for urgent issues. And so that's where it's really important to have an eye care provider on site when it comes to needing medications or anything like that. It is something that I really do think we can work on and continue to collaborate.
So where do we start in terms of, pushing this forward and getting eye care? And this is a statewide thing. We go from state to state to state and do it. We're all in our own areas and we have our own kind of nuances of healthcare and locally. Where is the starting point? Is it an organized effort or is it a more local effort?
Well, I'll take that one and then let everybody else respond. I think it's both. In short answer, I think it requires a top-down as well as a bottom-up approach. I think both are equally as important, equally perhaps as effective. It depends on the given state of affairs in our United States legislation, but I think it requires both. And so, but I think, so then I'll let Luke maybe address this. Certainly the bottom-up approach, which we've talked about a lot with the state primary care associations. Amy gave a great example of the relationship with the Mass League and how robust that is and how important that is. Matter of fact, I'll just give a shout out. I did my training there and that was my first experience where I caught the health center bug. And so I owe that to my training there. So I would want to say that. But I think that, again, relationships matter, collaboration matters. And I think we do need to start with our state associations. And sometimes they will have challenges depending upon what pocket of what area of the country one might be in. With workforce, there may be health centers that they're welcoming to have eye care there, let's say in North Dakota, but they can't find an optometrist to save their lives on. But I think we need to do a better job ourselves of educating, getting residents or optometry students, medical students even sort of interested in this so that we can develop a pipeline. but I'll let Luke maybe answer that from the bottom up approach.
Yeah, building off of that, as Amy mentioned earlier with the Mass League, and they have the Eye Care Forum that provides support to the optometry directors across the state. I've been looking for other examples around the country that do something similar to that, and there hasn't been any. And then all of a sudden, the Ohio Primary Care Association just hired or expanded the role of their director of oral health access to also cover vision services. And she actually talked to Mass League, is following their example. And then after meeting her just recently and talking, she did it with her whole network across the country of other people working at PCAs and oral health access. She is now putting out the word, who's going to be the lead? Who is the lead? Do you have somebody as a lead, or who would be interested in being a lead at their PCA in this space? So that's something that can start building up. And we've been talking in our Vision Services Committee of, if you know of other eye care providers at health centers within your state, connect with your PCA, because that's what it took at Ohio, was several people at their several optometry directors reaching out to the PCA saying, we want help with this, we want support. And so they started doing that.
That's great. So just for everybody on the call, I think PCA stands for Primary Care Association, is that right? And are those the folks who, are they connected with the community health centers, or what's the relationship there?
So they're membership organizations at the state level that are given federal funding, HRSA funds, to provide training technical assistance to health centers on a wide variety of different issues. They also do policy and advocacy work for health centers. So there's a lot of, that support for training and education. They can take, Medicaid reimbursement issues up to the state, those sorts of things.
I
That's
just want to
great.
mention one thing just to put in perspective, because I know we touched upon this a little bit, but I think numeric perspective will be helpful. So we talk about Massachusetts a lot and the model that we have there with the health centers and with the college, NECO. But I think the point, I can't remember exactly who brought it up, the uninsured rate in Massachusetts, according to a 2024 survey, was less than 2%. And that is extremely important to keep in mind, because if we're going to look to Massachusetts to be some type of model for the rest of the country, it's perhaps not entirely realistic because I've been working in Massachusetts. I didn't go to NECO, full disclosure. I caught the health center bug just by working here. But I can't remember the last time I saw a patient that didn't have health insurance. And that is pretty incredible to be a clinician and to be able to say that. But that is by nature because the uninsured rate is so low in Massachusetts. And I almost have to remind myself of that when I'm talking to colleagues that practice in other parts of the country. So I think we have to just be a little bit careful when we look to Massachusetts as a model, because you're not going to be able, aside from the fact that we have a school that has an optometry school that has a very unique educational model that is wedded to the health center network, which is wonderful. But from a reproducibility perspective, that is going to be very challenging from a health economics perspective and from a financing perspective, because other states are not going to be able to do that purely from an insurance perspective, aside from all the other barriers and obstacles that we'll have in the way, whether you're talking about a top-down approach or bottom-up. Massachusetts is quite generous when it comes to the benefits that they choose to provide on a state level compared to most of the other states in the US. And so I think that's an important thing to make sure that you're keeping in mind as we have this conversation.
And Dana, is it both in terms of refraction care, like with glasses, as well as medical vision issues, or eye
Yes,
issues?
actually it is. Yeah. So Medicaid provides routine care for adults every 2 years. And that's basic routine refractive care. Every 2 years, they'll provide spectacles and a routine exam for adults every 2 years. And then medical care, as needed, there's more intricacies to that. But yes, that does include routine care.
Okay.
So
So the
that's
state
quite
funding
generous.
is key, and I think the state by state, looking at the state by state way may be helpful. And I think Luke, that's what you're alluding to too, that you're looking at it in each state's situation, because I think this is how you go New York, California, Massachusetts may be very different than Michigan, right? So that's something to explore. Any other questions out there? I'll hand it over to my dean. Any questions on your side? You're from Ohio and you guys are doing a lot of great work. Any questions on this?
Well, I think part of it is just sort of the fragmentation. I think it is really an issue, even within different states. I mean, there's stuff that's happening in Ohio that's happening probably in the Columbus area where I'm at that I'm unaware of. So I think part of it is that's why I think these meetings turn out to be particularly important, because I think it's starting to reduce the fragmentation a bit. And I think people are starting to figure out how things are networked and what things we can use as an example in where we have to be careful. I think Diane's point is really important, is that some of these things are going to be state specific, but I think if we look at the different states and sort of outline, what are the resources that they're putting into this, and we can come up with some sort of cost benefit analysis, then maybe we can start to bring it to our own states and say, hey, look what's happening in Massachusetts. Keep in mind that there's different resources available, but this is what they're putting into it, and this is the return on the investment they're getting. So I think that these conversations turn out to be particularly important, because I don't know that even within the optometry community, there's tons of really good stuff going on that I'm unaware of. So I think that these opportunities turn out to be really important, and I think if we can use some of this information to figure out, okay, what are the outcome metrics we want to see for some of these things as a group, so that we can sort of start to make some of those comparisons. I think that would be helpful.
And Susan, I feel like you should add here about UDS 2.0, because there's not enough data for us to be able to make the arguments we want to make.
Yeah. Well, there's essentially, eye and vision care, there's no metric or quality measure within the UDS data set that addresses this. We've sort of begged for this, and well, it's not there. And so we have very limited, anything in the UDS data. Now, there is supposed to be UDS plus. Luke may be able to talk more about that. That was supposed to be coming out, I believe, within the next year or two. And I'm understanding that may be either sidetracked or delayed or derailed. I'm not sure what the best term is. But this is why it's so important that any of you that do research or anything around this area, that we can begin to develop these metric and these data sources, because right now from Healthy People 2030, increasing community vision on-site vision care in community health centers is still a research objective, because there is no data set that we can refer to that can have it come out of research objectives. So I think that's certainly a priority as well. But yeah, so I mean, I think that we just have to continue to chip away at this and to figure out what data we need. But it certainly starts with the UDS data set being incomplete, and sort of, advocating for that to be a little bit more robust on the eye and vision care side. I don't know, Luke, if you have any knowledge of UDS plus that's supposed to come out, or.
Last I heard, I think everything's on pause.
Yeah.
With, the reorganization, everything like that going on at HHS.
Yeah.
But yeah, that's all I know.
So data is the key thing. Diabetes and kids. Those are the two areas that we know that, children's screening and diabetes, at least biannual screening every 2 years is sort of what the quality metric is, right? So those are the places to start, and that's why New York had such a big push for their eye care and federally qualified health centers to meet that diabetes metric, really. And so I think those are the things that we can at least start with and kind of work towards a more inclusive way. It's good to learn from our folks in dentistry, as I keep saying. I mean, they sort of have made a push in this. I don't know if they're part of that 330 clause there of primary care, but hopefully we'll learn more as we go on. And next month, on the 27th of October, we have Dr. Lisa Hark from Columbia, who is on this call, I think. I know she's still there, but she's going to be presenting on some of our community outreach work in Colombia and talking more about the importance of engaging the community in this way. So it's an ongoing discussion. In November, I think it's around the 15th, we're going to have Paula Ann Newman Casey, Dr. Paula Ann Newman Casey from Michigan, talking about their work in this space. So boom, 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 we're going to have a lot of information on this. So please do come and 3 to 4 o'clock Eastern, we're going to have more discussions around this. And this may be a central theme to talk about at ARVO coming up if this becomes more and more of a area that we all want to focus on as a group here. So Vision 2020 is a group here bringing optometry, ophthalmology, and all those championing vision together. And we thank Prevent Blindness for giving us a lot of support in this. And hope to see you at our next meeting on the 27th of October, same time, same place. Great. Thank you again for a presentation. This was a wonderful. Good to see you all, and have a good week.